Hey guys, Hunter Hicks again. Today we're going to look at cyclooxygenase inhibitors or COX-1, COX-2 inhibitors and antihistamines. So let's first talk about our antihistamines. So relatively what we're doing here, and talking about a little bit of our physiology, is our mast cells and basophils are filled with histamine. Well, whatever it might be, whether it's allergic or non-allergic, they've released a large amount of these histamines, which create all these things that we're trying to block with these medications. Now, usually what we see is this IgE antibody binding to the mast cell and releasing histamine. Histamine release has H1 receptors and H2 receptors. H2 receptors are pretty easy. They're in the belly and they work on the parietal cells to release more gastric acid. We're not really talking about those today. We're talking about our histamine 1 receptors. So our histamine 1 receptors do things like increase vasodilation, increased permeability. So increased vasodilation is where you kind of see that redness if you're having an allergic reaction or if you're just having a reaction on your skin. Increased permeability is what we normally call as edema because the capillaries get leaky, allow proteins to release and pull more fluid into the interstitium. We can also see things like bronchoconstriction, sleep-wake cycle is also regulated by histamine, and itching, pain, and mucus. So itching and pain we know we get with a rash, so you kind of see all those. So I tell people, like, look at your typical rash and think about how much of that is histamine related. So we have the redness, which is vasodilation. We have the swelling, which is increased permeability. We have the itching and pain, which we know is coming from the histamine. And amongst that, we can get all the other things that we see there. So if we block that, it helps out a lot here. Now, we break down our antihistamines into first generation and second generation. First generation antihistamines would be things like Benadryl and promethazine. These guys notoriously make us sleepy and sedated. That is one of the most common side effects we see. Whereas second generations don't do that as much. So some of the effects where we give this medication, like I just said, are decreased redness, edema, pain and itching, decreased mucus, but we can also block our muscarinic receptors. Remember, when we block muscarinic receptors, we call that an anticholinergic effect. So things like dry mouth, palpitations, and things like that may occur with antihistamines. I do want to make a note that yes, usually we do get sedation with antihistamines, but overdose sometimes can cause hyperstimulation. And some patients get paradoxical effects, meaning not normal effects, that they get a heightened response when taking antihistamines. So again, when we look at some of our uses, mild allergies are going to be helpful here. We can usually use them for motion sickness, which we know a good example here is promethazine or Dramamine, which some people use for vertigo. Some people will also use this, obviously, when they're flying. Insomnia makes sense because we know chemicals like histamine and orexin make us wake up. So sometimes we give a medication like suvorexin to block that, or just antihistamines. We know this is super common. I mean, look at any like antihistamine that people take to help them sleep, like ZzzQuil. Almost always has a first generation antihistamine in there to also help you sleep and also help with all the side effects you're seeing with your sickness. Now, like I said, sedation is very common with our first gens like promethazine and Benadryl. However, second gens, which we commonly call these trade names like Zyrtec, Allegra, Claritin, are great because you can take them and get the antihistamine effects like the runny nose, the congestion, the inflammation and all that, the conjunctivitis of your eye, any of that stuff, but you won't get the sedating effects as much. So that's why Zyrtec, Allegra, Claritin, those second generations really promote the fact that they don't cause sedation. The really big difference between Benadryl and, let's say, Allegra is that Benadryl, a first generation antihistamine, is much smaller and it's more lipid soluble, making it easier for it to cross the blood-brain barrier and causes sedation effects in the central nervous system. Whereas Allegra or Claritin are a lot larger and non-lipid soluble, so they cannot cross that blood-brain barrier as well, so they don't get into the brain to cause this, the sleepiness. In general, we need to be careful with antihistamines with some of our older patients. It can cause things like confusion, dizziness, obviously always put them at risk for falls. Asthma is an interesting one. We don't really use antihistamines in asthma. Remember, asthma is usually a type 1 hypersensitivity reaction to some kind of thing to cause bronchoconstriction, increased mucus, and edema in the airways. However, it's different than what we see here with histamine. So it doesn't really help. If anything, the anticholinergic or antimuscarinic effect would actually make the secretions more thicker and harder to get out, so it actually can make them worse. GI effects are super common with antihistamines, things like nausea, vomiting, diarrhea, we can see, and then the anticholinergic effects like dry mouth and palpitations. Now let's talk about our cyclooxygenase inhibitors or COX-1, COX-2 inhibitors. In general, what we're trying to block is we know cyclooxygenase will eventually give us prostaglandin. Prostaglandin has a ton of different things it does in the body, and let's look at them. So at a site of injury, prostaglandin or a cyclooxygenase will give us things like pain and inflammation. In the vascular region, it'll give us vasodilation. In the stomach, it's actually protective. Prostaglandin is protective here, meaning it increases sodium bicarbonate. It'll increase sodium bicarbonate, decrease gastric acid from parietal cells, and increase flow to the submucosa. In the kidneys, it'll increase renal blood flow, which is protective. Platelets, it actually decreases TXA2, so it decreases the platelets clumping together. In the central nervous system, we know fever and pain is where we're going to see a lot of that there. And then in the uterus, prostaglandin in the uterus actually stimulates contraction. So if we block them with these medications, we might prolong labor because we're blocking contractions. Now let's look at COX-1 versus COX-2. So now we understand what cyclooxygenase does, and we know it gives us prostaglandin, and I just showed you everything it does in the body, but there's different receptors that just basically use it a little bit differently. So COX-1, we actually call the good kind of cyclooxygenase. The reason for that is because it really is linked to all those things I said before, protective-wise. So stomach and the kidneys, and then it blocks platelets from forming. So it's really good. But that's why when we block COX-1, we get all the bad stuff. If we block the prostaglandin protectiveness in the stomach, we're more likely to get gastric ulcers, gastric bleeding, stuff like that. If we block the prostaglandin COX-1 receptors in the kidneys, we're more likely to get renal failure. If we block the COX-1 receptors in the platelets, it's actually a good thing. Well, if our platelets don't clump together, we're less likely to clot. Therefore, it's good for strokes and MIs. But in general, blocking of the COX-1 is really where we see all the bad effects of these meds. Blocking of the COX-2 receptors are all the pain and inflammatory stuff we talked about that we're really trying to block. So when we give this med, we're like, hey, we're trying to block more of the COX-2 stuff, but the side effects come from the COX-1. Outside of the antiplatelet effects that we're going to see with aspirin here in a second, which come from COX-1. Oh, and I should add too, blocking COX-2 is good in the fact it does protect against colorectal cancer, which we know aspirin could be helpful there, but bad because it promotes MI and stroke. So let's talk about the two different groups of our COX-1, COX-2. So it's broken down in two separate ways. First of all, in general, cyclooxygenase inhibitors can be anti-inflammatory or not. Anti-inflammatory, we kind of just call it NSAIDs, so ibuprofen, Motrin, Aleve. Non-anti-inflammatory cyclooxygenase inhibitors are Tylenol. We'll talk about why they're different. Then NSAIDs are further broken down. NSAIDs are going to be first generation COX-1, COX-2, and second generation. Our first generation are going to block both COX-1 and COX-2, so that's classic aspirin and ibuprofen. And then COX-2, which we call our COXIBs, is going to be like Celebrex. The idea here is that if we only block COX-2, the bad stuff, and don't block COX-1, the good stuff, well, we should block all the bad stuff and get relief of pain and inflammation and have no issues with the gastric and renal stuff. We'll talk about why that's not as true. So aspirin's a good first one to start. So aspirin is going to be a first gen. He's going to block both COX-1 and COX-2. Aspirin's a little bit unique as a NSAID because aspirin comes from a chemical family called the salicylates, which is why some of its side effects occur. Now, some of its uses is it blocks inflammation. Aspirin's a great medication for rheumatoid arthritis, osteoarthritis, and juvenile onset. Moving forward, sorry, I just got a phone call. It's good for analgesia, so it can help out with headaches and stuff as well. We know it's good for reducing fevers. However, we don't want to ever give aspirin to someone under 18 years of age because it increases something called Reye syndrome. And we know it can decrease colorectal cancer risk. But the biggest thing we love, love, love aspirin for is that aspirin's going to block platelets from sticking together. And it does it because it blocks cyclooxygenase for the full life of a platelet, which is around 8 days. It's this irreversible blockage for the whole life of the platelet. Whereas our other first gens, like ibuprofen, kind of has this effect, but it doesn't block it like aspirin does, and it also is a reversible blockage. So that's why aspirin has been proven time and time again to decrease mortality for our patients that are having an MI or a stroke at times. This is why a lot of patients that have history or at risk for stable or unstable angina, MI, ischemic stroke, and then patients getting an angioplasty, a lot of times they're going to be given aspirin because we know it can help out. Now, people ask me all the time, they're like, well, why isn't everyone just taking aspirin? Like, let's just take 81 milligram aspirin every day. Won't that increase all of our risk for stroke and heart attack? Well, they tried that. And really what they found is it only really does this beautiful, nice protective thing if you're sick, like if you have chronic diseases. If you're healthy, and you're fine, and you're normal, the side effects or the adverse reactions like GI bleeding, renal flow, and stuff like that is going to be worse and outweigh the benefits. Now, all the side effects of aspirin. Now, aspirin is going to be a unique cyclooxygenase inhibitor, whereas ibuprofen and Motrin are the same thing. And Advil, all those guys share the same side effects, but not to a degree that aspirin does. So some of the things we'll see in general with our cyclooxygenase inhibitors are going to be, first, starting with the stomach, increased risk for gastric ulcers, bleeding, gastritis, all those things. People that smoke, drink, older people, people with history of gastric issues, you should be really careful giving them NSAIDs. And in general, if you're going to give them aspirin especially, you want to give it with an H2RA or a PPI to help block the effects. Remember, aspirin blocks cyclooxygenase. The cyclooxygenase gives us prostaglandin in the stomach, which we know increases bicarb, decreases gastric acid release, and increases submucosal flow. If we block all that, we put our risk at ulcers. As far as vaccines, we'll talk about this, but aspirin actually decreases the immunogenicity of vaccines just like Tylenol does. So we're not really wanting to give it to people that are like, oh, I kind of feel like crap after that coronavirus vaccine or something like that. We want to give them more like maybe ibuprofen. Bleeding tendencies are very high risk for aspirin, more than other cyclooxygenase inhibitors because it blocks the platelet for its entire life. Now, this is kind of an off rule here, but patients with high blood pressure are at risk for hemorrhagic stroke, right? Because we know we're just constantly putting pressure on those arteries. So the idea here is if you're going to give someone aspirin, increased risk for bleeding, now you have increased risk for hemorrhagic stroke if they have high blood pressure, you should try and treat their blood pressure as well before starting that. Renal impairment's pretty obvious. We know that prostaglandin increases flow to the renal, to the kidneys. Therefore, if we block that, we put ourselves at risk. Rye syndrome is unique to aspirin, where kids under 18 years of age, especially kids with chickenpox or influenza that are taking aspirin, put themselves at risk for Rye syndrome. Rye syndrome will cause kiddos to have encephalopathy, which we know is a disease of the brain, and then also fatty liver syndrome. Salicylate toxicity, so taking too much aspirin will cause salicylate toxicity. And some of those signs and symptoms can be things like tinnitus of the ear, sweating, they can get respiratory alkalosis, and then they also get a mixture like metabolic alkalosis here as well. So be careful if you ever have someone that comes in that says they took an overdose of aspirin, you're thinking salicylate toxicity and you're going down that algorithm. In general, we don't want to give aspirin and some of our NSAIDs to pregnant patients. Why? Because, well, if we block prostaglandin, which we know induces contractions, we're going to prolong our labor, and not to mention we're going to increase our risk for bleeding. Now let's kind of look at these first generation cyclooxygenase inhibitors, aspirin versus ibuprofen versus Aleve, all those guys. Well, in general, they kind of do the exact same thing, but it's a little bit different. Aspirin is the only guy that's been proven to be very protective for MI and strokes, whereas ibuprofen and those guys don't really have that same effect. Outside of that, they have the same side effects, but remember, ibuprofen is not from the salicylate family, so you don't have that issue with salicylate overdose and Rye syndrome, which we see way more with our aspirin people because they come from that family. Outside of that, we know ibuprofen has been proven to be more helpful for ladies that have dysmenorrhea, which is going to be that painful menses, which we know we can see in our younger population just in general, or we can see in our older population maybe with a history of endometriosis. The idea here is when we're having these menses, we're having the shedding of the endometrium, which then causes release of prostaglandin. That prostaglandin causes contractions possibly in the uterus, which then causes ischemic injury to the uterus, which then causes a pain. So if we block the prostaglandin, we're going to get less of those contractions, therefore it doesn't hurt as much. Ibuprofen has been proven to be one of the better ones for painful menses. Now let's look at our COX-2. So COX-2 only block COX-2 receptors. We call these second generation cyclooxygenase inhibitors. Great example, everyone's seen it out there, is going to be Celebrex. Well, the idea made sense. Let's only block COX-2 receptors, which is the pain and inflammation, all the crap we're trying to help these people with, and not block COX-1, which protects our stomach and our kidney. Well, it was kind of working, but then people over a while were taking these and they kind of did the data and they're like, they're really not that much more protective than COX-1. And what we found is by blocking COX-2 receptors, we increase vasoconstriction, which already puts more pressure on our cerebral arteries and veins. And by not blocking COX-1, remember the only bad thing about COX-1 is that the platelets like to grab on and form more. So now we're not blocking that, plus we're getting vasoconstriction from COX-2. So vasoconstriction with platelets liking to stick together, now they put us at actually increased risk for MI and stroke with our COX-2 or second generation cyclooxygenase inhibitors. Last but not least, Tylenol. Everyone gives it, but sometimes we forget how it works and really what it actually does. So Tylenol by trade is a cyclooxygenase inhibitor. He does a great job, but he's actually a little bit different. The idea here is he only works at the cyclooxygenase inhibitors in the brain, which is why he's super good at treating pain and fever, but not good at treating anti-inflammatory effects that we see in the periphery. But the good thing about that is because he can't treat the cyclooxygenase that we see more in the periphery, he doesn't get the side effects like gastric ulcers and decreased renal perfusion. So there's a good and a bad. Now, in general, Tylenol is metabolized two ways, the major pathway and the minor pathway. The major pathway, majority of our Tylenol, takes our Tylenol and then converts it into non-toxic metabolites. All good, fine. A small amount in a healthy patient goes through something called the minor pathway, where we take Tylenol and it's broken down by the P450 enzyme and we get toxic metabolites. Those toxic metabolites are very toxic to the liver. Now the good thing is that those toxic metabolites are going to be further broken down by an enzyme called glutathione or glutathione. The good thing is he then takes those toxic metabolites and puts them into non-toxic metabolites. However, this is where overdose and drinking can be especially bad with Tylenol. Drinking induces our body to take the Tylenol and go through the minor pathway with that P450 enzyme. Drinking also decreases our amount of glutathione. Therefore, major pathway is happening and we don't have the antidote to those toxic enzymes to the liver. Therefore, it can be more toxic to our liver if we're drinking while taking Tylenol. Outside of that, if someone overdoses or takes too much Tylenol, it induces the body to go through the minor pathway and our glutathione is going to be less and less, which is why a good antidote for Tylenol is Mucomyst, which naturally does the same thing that glutathione does and takes our toxic metabolites to non-toxic metabolites. Now, in general, guys, Tylenol is a great thing to use for pain and fever, not inflammation. Tylenol has been proven to be safe in kiddos, so we tend to give this one more in kids because it doesn't cause the Reye syndrome we see with aspirin. However, if a kiddo has a vaccination, Tylenol has unfortunately proven to decrease the immune effects of the vaccination right after giving it, so you're not going to want to give it for that kind of just aches and pains that you sometimes get after a vaccination. Well, it's not helpful with inflammation, but the good thing is because it doesn't do the cyclooxygenase inhibitors for inflammation, it's safer for the gastric and renal patients that we have. Guys, that was down and dirty on the cyclooxygenase inhibitors and antihistamine medications. If you have any questions, leave me a comment, give me a like if you like, and I'll see you next time.